Hello everyone, in this series of orthopedic video. So today I will be talking about treatment of fracture, about its general principle, and it is one of the very most important and basic chapter that is very highly important. And because in every other chapter the principle that has been discussed in this chapter will be applied again and again. So if we can master this chapter, then our remaining orthopedic, especially in the trauma section, will be very easy. So let's start without delay. So for the treatment of fracture, the treatment of fracture can be considered in three phases. Phase one is emergency care, phase two is definitive care, and the phase three is rehabilitation, EDR. And the first phase is emergency care, and the emergency care begins at the site of accident. The emergency care of fracture begins at the site of accident, and in the principle it consists of RICE therapy, and which means that REST. R means rest to the part by splinting, ice therapy to reduce the occurrence of swelling, and the compression to reduce swelling, and the elevation to reduce swelling. These are done. This ICE are done for reducing the swelling, and the rest is done by splinting. The splint them where they lie, and before applying the splint, we have to remove the ring or bangles worn by the patient, and almost any available object at the site of accident can be used for splinting. Like for example, we can use the folded newspaper, magazine, rigid cardboard, stick, umbrella, pillow, wooden plank, and any available long piece of cloth can be used for tying the made of splint. So some of the example of the fractured extremity at the site of accident are shown in this given picture. So this is splint made by folded newspaper, foot rule, pillow, chest arm bandage. We can see the wooden plank, bamboo ring, triangular string, and umbrella. And one can correct any gross deformity by gentle traction. It might be little painful but desirable, and we should feel for the distal pulses, and we have to do the quick assessment of the nerve supply before and after the splinting. And absence of pulse is a very dire emergency, and its consideration has to be made to shift the patient to the facility equipped for taking care of the vascular injury. And the advantages of splinting are that there will be relief of pain by preventing movement at the fracture. There will be prevention of further damage to the skin, soft tissue, and neurovascular bundle of the injured extremity. And there will be prevention of the complications such as fat embolism and hypovolemic shock. And the transportation of the patient will be easier. And in the ice therapy, the immediate application of ice to the injured part helps in reducing pain and swelling. The icing can be done by taking the crushed ice in the polythene bag and covering it with a wet cloth. And commercially available ice pack can also be used. And any wound, if present, has to be covered with a sterile cloth. And the compression, the creep bandage is applied over the injured part, making sure that it is not too tight. And elevation, the limb is elevated so that the injured part is above the level of heart. For this, one can use the pillow, and for upper limb, sling and pillow can be used. And nextly, in the emergency department in the hospital, soon after patient with musculoskeletal trauma is received in emergency department, one has to be coordinated way. We have to follow the advanced trauma life support ATLS principle, and which consists of primary survey with simultaneous resuscitation, identification, and treatment of what might be killing the patient. And it consists of ABCDE, that is airway and cervical spine protection, breathing and ventilation, circulation, and control of bleeding. And disability and exposure, we have to check for this any neurological damage. We have to do the exposed patient from head to toe. We have to do the resuscitation and management of shock to be done simultaneously. And in secondary survey, we have to proceed to identify all other injury, and consist of review of patient by the quick history like allergy history, AMPLE, allergy, medication, past medical history, and ample allergy, medication, past medical history, last meal, and other intake, and event leading to presentation. We should do the quick history, and after that we have to do the physical examination for quick evaluation of any injured part and their extent for the injury. And limbs are examined to exclude any injury to nerve and vessel. Analgesic and antibiotic are as per needed, and radiological evaluation. So we will talk about ATLS principle in detail when we will be talking about surgery. And so for now, this is the first phase of the fracture treatment, that is emergency care. And now we'll move to the definitive care, and this is important as for the orthopedic view. So second phase is definitive care, and over the years the The treatment of the fracture, the philosophy of the fracture treatment has undergone rapid changes in philosophy. In the past, the aim of the treatment was a mere fracture union only. This could be achieved in most cases by immobilization of some kind, and with this the fracture would heal in most circumstances, but with residual joint stiffness, muscle wasting, etc., and that may result in less than optimal limb function recovery of limb as a whole. Nowadays the aim of the modern treatment, modern days, the principle of the definitive care fracture treatment is to get the limb function back to the pre-injury level. For this, early functional use of the limb as far as possible is desirable. So the perfect anatomical reduction and stable fixation is preferred for intra-articular fracture, and so that because early mobilization can be done in that case, and this is the most often possible only by operative method. And in diaphyseal fracture, the aim is to achieve union in good alignment and maintaining length, and which is achieved by non-operative method. And in case of fracture is unstable, sometimes the matter of comfort of early mobility, availability of the technical surgery, the trend is to treating more and more fracture operatively, as it gives more predictable result, and early recovery and better function is given by operative treatment. So we will now talk about fundamental principle of fracture treatment. The principle of fracture treatment consists of reduction, immobilization, and preservation of function of limb. The reduction is the technique of setting a displaced fracture to a proper alignment. This may be done by non-operatively or operatively, and it is so called as a closed reduction or open reduction. And the immobilization is necessary to maintain the bones in the reduced position, and it may be done by external immobilization such as plaster, or by internal fixation by rod, plate, screw. And preservation of function of limb, these are done by physiotherapy all through the treatment, even when the limb is immobilized and thereafter. So there are various methods of treatment, and not all three fundamental treatment principles mentioned above apply to all fracture. The treatment of particular fracture can fall in one of the following categories, and the one of the first treatment method is the treatment by functional use of limb. This means that the one can simply ignore the fracture and continue to use the limb. So can you tell me what are the such conditions of fracture where no treatment is needed? Oh, that is I will tell, that is the fracture of ribs scapula. We do not need any reduction or immobilization. These fractures unites despite functional use of the part. Simple analgesic and splinting are needed for initial few days, basically for pain relief only. And the treatment of immobilization alone, in some fractures, some mere just immobilization of the fracture is enough for the treatment, and the accurate anatomical reduction is not necessary. The fracture which are not displaced in the first place, or even if they are, the displacement is of no consequence in terms of eventful outcome. So displacement doesn't matter in some fracture. For example, some fracture of surgical neck of humerus, you can just treatment by immobilization only. And treatment by close reduction followed by immobilization. This is required for most displaced fracture treated non-operatively. The reduction could be done under mild sedation or under general anesthesia, or the immobilization is usually in the plaster cast. There is trend towards use of a special video X-ray machine called image intensifier, and once acceptable reduction is achieved, it is necessary to keep a close watch on position of the fracture in the plaster by taking frequent X-ray. And next method is close reduction and percutaneous fixation. There are fractures which though can be reduced by close manipulation but are unstable and have potential to get displaced subsequently. So these fractures are reduced under the image intensifier and fixed with percutaneous device such as K-wire, rust pin, and that is on. And next we have the open reduction and internal fixation, very famous one. There are some fracture which such as intra-articular fracture, where accurate reduction, stable fixation, and early mobilization are very important. So to regain the joint function, such fracture are best treated by open reduction and internal fixation. And some unstable juxta-articular fracture are also treated by ORIF, and the scope of this ORIF has expanded over there, and this is very popular. And nowadays mostly the ORIF is done. And next we have the minimally invasive open surgery. For the fracture which need operation, there is trend towards using minimally invasive technique. In the past, in order to fix a fracture, whole bone is to be exposed and then fixed. Though it was very technically easier for surgeon to do surgery, but this would often lead to the extensive soft tissue damage and also damage to blood supply of the bone. So often the X-ray would look good, but the bone would fail to heal, as extensive damage would cause blood supply of the bone by rather liberal open surgery. So in modern days, a trend is to do this operation by minimal exposure and hence minimal damage to soft tissue, and image intensifier is of great use in doing so, as it is possible to achieve reduction by indirect method by manipulating under image intensifier vision. The fracture is stabilized internally by using special devices such as rod, plate, etc. And these devices are introduced to the small incision using special instrumentation. A minimally invasive surgery has the advantage that the blood supply of the bone is preserved and thus early bone union occurs, and there is less pain, early recovery, and cosmesis are other advantages. And finally we have the primarily joint replacement. There are fractures in which the result of trying to achieve union are very little, and hence the broken part of the bone is replaced with the artificial part, prosthesis, and this is commonly used for hip fracture and the shoulder fracture. And which of the above method is used in the particle fracture depend upon the number of factors such as patient profession, whether the injured limb is dominant or not, surgeon's experience, availability of facilities, patient affordability, and many other factors. And so it is therefore common to see differing opinion by different surgeons on the treatment of the same fracture. So we are going to discuss the three fundamental principle of definitive treatment of fracture. So there's a reduction, immobilization, and preservation of function. So firstly, talking about reduction of fracture, not all fracture require reduction, either because there is no displacement or because the displacement is not significant to the final outcome. For example, the child's clavicle fracture doesn't need reduction because normal function and appearance will be restored without any intervention. So in general, imperfect apposition of the fragment can be accepted more readily than the imperfect angularity alignment or rotational malalignment. So perfect anatomical reduction is desirable in some fracture, even if this an operation is required. For example, the intra-articular fracture. So the reduction of fracture can be carried out by different methods. We have the three different type of method. One is closed manipulation, continuous traction, and open reduction. And for closed manipulation, this is the standard initial method of reducing most of the common fracture. This is usually carried out under general anesthesia and requires experience, and this is the art of realigning displaced bone by filling through the soft tissue. The availability of the image intensifier has greatly added to the skill of closed reduction, and it is not necessary that perfect anatomical reduction be achieved in all cases. The displacement compatible with normal function are considered acceptable, and the most fracture reduced by closed manipulation needs some kind of immobilization, like by pure plaster of Paris, brace, bandaging, etc. And the continuous traction, it is used to counter the forces which may not allow the reduction to happen, or forces that would cause redisplacement. These are the muscle forces and the force of gravity. A common example is that of an intertrochanteric fracture, in which the muscle attached to the different fragment cause displacement. A continuous traction can counter this force and bring the bones in proper alignment. Once maintained in groove position in traction, fracture heals predictably. Though continuous traction is easily available and cost effective, it has its own problem. These are problem of keeping the patient in bed for a long time with associated complications such as bed sore, and it is for this reason that one often practices a hybrid policy, which means that keep the patient in traction as long as it takes to become sticky, and once this happens, there is little possibility of redisplacement, and the traction is discontinued and the fracture supported in the plaster cast till healing occur. Many of these fractures which were earlier treated in the traction are now treated operatively due to uncertainty of result and need for long period of in-bed immobilization. And different method of traction are there, and we will be talking in some other video. And open reduction, next method is open reduction, and in this method the fracture is surgically exposed. Open reduction, in this method the fracture is surgically exposed and the fragments are reduced under vision, and once reduced, some form of internal fixation is used to maintain the position. and this is commonly referred as open reduction and internal fixation. This is the one area of the fracture treatment which is continuously evolving. There used to be time when the orthopedic ward used to be full of patient in traction and huge plaster cast for a month. Today, with the advancement in surgical treatment, the paradigm has shifted to the operative treatment. The big deciding factor for adopting ORIF as a treatment of choice is the facilities available and the training of surgeon. And the operative treatment of the fracture, though, has become preferred method of these days, but has to be done with care, as potential risks of surgery are often worse than the displacement or disadvantages of non-operative treatment. And one has to be clear. The one clear reason to do the open reduction is when other method of achieving reduction have failed. There are fractures which are so unstable that one knows that this fracture will re-displace in due course. In such fracture, open reduction and secure internal fixation is carried out in first instance. So indication of open reduction. For the absolute indication is the failure of caused reduction, the displaced intra-articular fracture, some displaced epiphyseal injury like type 3 and type 4 in the shoulder iris, and the major avulsion injury like fracture of patella and non-union. These are the indication for open reduction. And some other relative indication are delayed union, malunion, multiple fracture, pathological fracture, where the closed reduction is known to be ineffective, like fracture of neck of femur, and the fracture with vascular and neural injury. Now, after the reduction, next step is the immobilization of the fracture. And indication are not all fracture require immobilization. The reason for immobilizing a fracture may be to prevent the displacement of the or to prevent displacement or angulation. In general, if reduction has been necessary, immobilization will be required. And to prevent movement that might interfere with the union, so the persistent movement might tear the delicate early capillaries bridging the fracture, and more strict immobilization is necessary for some fracture like scaphoid fracture. And the immobilization is done to relieve pain, and this is the most important reason for immobilization for most fracture. As the fracture becomes pain-free, feel stable, guarded mobilization may be started. And the method, the immobilization fracture can be done by various operative and non-operative method. Talking about non-operative method, most fracture can be immobilized by one of the following non-operative method, like firstly, the strapping. The fracture part is strapped to an adjacent part of the body. For example, a phalanx fracture where the one finger is strapped to the adjacent normal finger. The sling fracture of the upper extremity is immobilized in a sling, and this is done mostly to relieve pain in cases where the strict immobilization is not necessary. For example, the triangular sling used for fracture of the clavicle. Next is we have the cast immobilization. We will talk about this later. And in the functional bracing, the brace is the type of cast where the joint are not included, so that while the fracture is kept in position, the joint can also be mobilized. And this method is commonly used for stable fracture of tibia and humerus, and it is based on the principle that the continuous use of the affected limb while the fracture is kept adequately supported rather encourage union and prevent joint stiffness. The brace is usually applied after the fracture becomes sticky, and in an experienced hand, the rate of fracture healing by this method is comparable to other method, and it is useful option at places where facilities for surgical option is not available. Next is we have the splint and traction. The splint of various design are used for definitive treatment of fracture. The Thomas splint is still very popular for treatment of fracture of the lower limb, and the advantages of this method of treatment are prolonged hospitalization and confinement. These are disadvantages of this method is prolonged hospitalization and confinement to bed, and this is hazardous especially in elderly people who develop complication secondary to the recumbency like bed sore, chest infection. And now we'll talk about cast immobilization. The cast immobilization is it is most common method of immobilization. The plaster of Paris cast has been used for a long time, and very lately the fiberglass casting tape has also become popular. The fiberglass casting tape provide durable, lightweight, and reduction cast. The plaster of Paris is also known as gypsum salt, and it is calcium sulfate hemihydrate in dry form, which becomes calcium sulfate and 2H2O. It is calcium sulfate half H2O, and when it is wet, when it is mixed with water, it becomes calcium sulfate dot 2H2O. And this conversion is the exothermic reaction and irreversible, and the plaster set in the given shape on drying. The setting time of the plaster varies with its quality and temperature of the water, And the name of some there are various name of the some cast, like the Minerva cast for cervical spine disease, research cast for scoliosis, turnbuckle cast for scoliosis, shoulder spica, U slab, hanging class, Collis cast, hip spica, cylinder class, PTV cast. So these are fancy name for various casts. The type of plaster bandage, there are two types of plaster bandage in use. One prepared by impregnating the rolls of starched cotton bandage with plaster powder, that is homemade bandage, which were widely used in the past, but they have been replaced by ready-made plaster bandage available on proprietary bandage. And the use of plaster of Paris, it can be applied in two form: slab or cast. A plaster slab cover only a part of the circumference of the limb. A slab covers only a part of circumference of the limb, and it is made by unrolling a plaster bandage to and fro on the table. And the average slab is about 12 inches thickness, and slab is used for immobilization of the soft tissue injuries and reinforcing plaster cast. And a plaster cast covers the whole circumference of the limb, and thickness varies with the type of fracture and the part of body on which it is applied. And some of the fundamental principles to be remembered while applying plaster casts are we have to immobilize the joint above and below the fracture, immobilize the joint in functional position, and pad the limb adequately, especially over the bony prominences. And after care of plaster, this involves noticing any crack in the plaster, avoiding wetting the plaster, and graduated weight bearing of the lower limb fracture, exercising the muscle within the plaster, and moving the joint that is not in the plaster is necessary to ensure the early recovery. And the complication of plaster treatment, like there will be impairment of circulation if the tight cast has been applied. The plaster cast is a closed compartment, and the hematoma and tissue edema after fracture can result in increased pressure inside the cast, leading to the impaired circulation of the extremity. And if not diagnosed early, this can result in disastrous complications such as gangrene. And key to early diagnosis is high index of suspicion, unrelenting pain not settling with the usual dose of analgesic, swelling over the finger and toes, inability to move them, stress pain, hypoesthesia, and bluish discoloration of digit. Tight cast can be prevented by the adequate padding of the cast and elevating the extremity for first 2 to 3 days following cast application. And then there can be plaster sore. These are caused by inadequate padding, irregularity of the inner surface of the cast, or foreign body in the plaster. A sore formation within the plaster can be suspected by the various symptoms like pain out of that is proportion to fracture, irritable nature of patient, disturbed sleep, recurrence of swelling over toe and finger, low-grade fever, patch of blood soaked over the cast. And the plaster sore can be prevented by examination of the suspected area through a window in the cast, and it is possible to dress a small sore through this window. And occasionally plaster has to be removed and reapplied. And the blister inside the plaster, sometimes when a plaster cast or slab is applied to a fresh injury, due to ensuing edema and skin stretching, blisters develop inside the plaster. And the prevention by adequate padding and opening the plaster if too much pain is way out. An operative method of the operative method of immobilization, whenever open reduction is performed, a fixation, internal or external, should be also used. And the external fixation is usually indicated in situation where for some reason internal fixation cannot be done. And the internal fixation, there are in this method the fracture once reduced is held internally with the help of some metallic or non-metallic device that is also known as implant, such as steel wire, screw plate, Kirchner wire, K-wire, intramedullary nail, etc. And these implants are made of the high quality medical grade stainless steel to which the body is inert. And the indication or the internal fixation of fracture may be indicated under the following circumstances, like when the fracture is so unstable that it is unable to maintain its when it is difficult to maintain its in an unacceptable position by non-operative means. And this is most frequent indication for internal fixation. And it is the treatment of choice in some fracture in order to secure rigid immobilization and to allow early mobility of patient, and when necessary to perform open reduction for other reason like neurovascular injury. There are various the fracture can be fixed internally by the combination, any one or combination of various implant, and some of the implant are the like steel wire. These are used for internal friction, a small fracture like fracture of patella and comminuted fracture of large bone. And these are 18 to 20 gauge steel wire. And the Kirchner wire, this is straight stainless steel wire, 1 to 3 mm in diameter, and it is used for fixation of small bone of hand and feet. Intramedullary nail, the nail is called misnomer, but it is in fact a hollow rod made of stainless steel, and it can be introduced into the medullary cavity of long bones such as femur and tibia, and it can be inserted into the medullary canal from the proximal to distal antegrade nail, or from distal to proximal retrograde nail. And different shape of this and sizes of this nail are available. And the screws, these can be used for fixing a small fragment of bone to maintain bone to the main bone. For example, fixation of medial malleolus, screw can be used. And the plate and screw, these devices which can be fixed on the surface of bone with the help of screws. Different thickness, shape and size are available, and specific fracture specific implant are available, and the combination of these above method can be used. So we'll be making separate video on the various different implant, and we'll be talking about that in some other video. The advantage of internal fixation is that with the use of modern technique and implant, there is minimal need of external mobilization, and it allows early mobility of patient out of bed and hospital. Joint do not get stiff, and muscle remains very good. Muscle function remain good. The complication associated with confinement of patient to bed are also avoided. And the disadvantage of internal fixation are infection and non-union. It needs trained orthopedic surgeon, free availability of the implant, and good operation theater. If failing of which result in internal fixation may not only poor but disastrous. So now next we have the external fixation. It is a device by which the fracture is held in steel frame outside the limb. So for this, the pin are passed percutaneously to hold the bone and connected outside to a bar with the help of clamp, and this method is useful in treatment of open fracture, and where the internal fixation cannot be carried out due to risk of infection. And these are the following type, like tubular fixator. These are 3 to 4 mm size steel pin passed through the bone percutaneously and are held outside with the help of variety of tubular rod and clamp. And nextly we have the ring fixator. In this, thin K wire are passed through the bone and same are held outside the bone with the ring. Now next we have the phase 3, and this is the rehabilitation of fractured limb. The rehabilitation of fractured limb begins at the time of injury and goes till the maximum possible function have regained, and it consists of joint mobilization, muscle re-education exercise, and instruction regarding the gait training. And the joint mobilization, the joint adjacent to an injured bone tends to get stiff due to the immobilization, inability to move the joint due to the pain, and associated injury to joint as well. And to prevent stiffness, the joint should be mobilized as soon as possible. And this is usually initially done by passive mobilization. Someone else does it for patient. And once pain reduces, patient is encouraged to move the joint by himself with assistant, that is active assisted. And after active assisted or move joint by himself, that is also known as active mobilization. So initially passive mobilization, then after that active mobilization. And motorized device which slowly move the joint through predetermined range of motion can also be used, and these are called continuous passive motion CPM machine. And techniques such as hot fomentation, gentle massage, and manipulation aid in joint mobilization. And functional use of bone muscle re-education exercise. Because of lack of use, the muscle gets wasted easily quickly, and hence it is desirable that muscle activity be maintained all through treatment, and this can be done even during the immobilization, the static contraction, or after removal of external immobilization, that is dynamic contraction, as discussed below, as we will discuss. And during immobilization, even while a fracture is immobilized, a joint which are out of the plaster should be moved to prevent stiffness and wasting of muscle. Such movement do not cause any deleterious effect on position of fracture. The muscle working on the joint inside the plaster can be contracted without moving the joint, that is also known as static contraction, and this maintains some function of the immobilized muscle. After removal of immobilization, after limb is immobilized for some period, it gets stiff, As the plaster is removed, the following care is required, that is, skin should be cleaned, scale are removed, and some oil are applied. Joints are moved to regain the range of motion. Hot fomentation, active and passive assisted joint mobilizing exercise are required, and the muscle wasted due to prolonged immobilization are to be exercised. And the functional use of limb, once a fracture is on the way to union, at a suitable opportunity, the limb is put to the use in guarded way. For example, in lower limb injury, the gradual weight bearing is started, the partial followed by full, and one may need to support the limb in the brace, caliper, and cast. And walking aids such as walker and pair of crutches stick may be necessary. And at last, finally, we have the general plan for treatment of fracture. This is a summary. For fracture, if we have to do the examination of neurovascular injury. If the fracture is undisplaced, we have to do immobilization and physiotherapy. If it is displaced, we have to do either primarily ORIF and we have to finally do the physiotherapy. And if in the displaced, if we do closed manipulation, closed reduction, we have to do manipulation and traction. If the position is acceptable, we have to do immobilization and finally physiotherapy. If the fragment are in unacceptable position, we have to do ORIF and finally the physiotherapy. So that is all. Thank you, and we will come up with the next topic in the new video. Thank you for being with me till this long video. Thank you.